And I'm glad we'll be talking about implementation science today. I think it may be top of mind for people using the Wahova app. So what a great conference so far. I hope people have had a chance to attend some of the great sessions and keynotes and panels. And I will say in the early hours of day 3, I think that a conversation around implementation science and climate and health research is going to be well received and a great opportunity for attendees to learn from the 4 of you about what implementation science is and how it can be applied to climate and health research. I think in particular, Dr. Vanessa Carey's keynote yesterday really was a wonderful clarion call to action for adaptation science and the importance of studying and generating knowledge around implementation and how best we can adapt. So I'm very thankful, and I hope everyone will join me in welcoming and thanking our speakers for joining us today. I'll do a quick introduction of the speakers and then hand it off to them. And I know that we had 99 people last I saw planning to attend. So I'm glad the only thing people are missing is my introduction, hopefully. So we will start with Dr. Laura Ellen Ashcraft at UPenn, who will talk to us. She'll provide a brief introduction to implementation science and talk about how it can be valuable at the nexus of climate and health research and environmental justice, which I know is a critical value for those participating in the conference, many of those, if not all of those participating in the conference. She will be followed by Dr. Saria Hassan from Emory University School of Medicine, who has done some great groundbreaking work in applying implementation science methodologies, and particularly participatory systems dynamics modeling, to addressing climate disasters in healthcare settings and their impact on managing chronic diseases. So she'll be able to better describe and summarize her work, but she has been a true leader in the implementation science community and thinking about how to apply these methods to climate and health challenges. She will be followed by Dr. Bill Pan at Duke University, who has been doing tremendous work in developing early warning systems in the Amazon, and worked with a group of investigators to think through implementation barriers to implementing early warning systems and applying some implementation science methods. So another great example of implementation science and applying it to early warning systems. And finally, Dr. Aruni Bhatnagar at the University of Louisville will share his tremendous work in greening, the Green Hearts Project, and working on green spaces. So we really have a nice range of adaptation interventions and applications of implementation science to that work. So with that, again, welcome those of you who are just joining. And we are going to get started with Dr. Laura Ellen Ashcraft. And Dr. Ashcraft, are you able to share your screen and your slides?
Yes. Is everyone able to see them and hear me?
Yes, you sound great.
Okay.
Great. Thanks.
Excellent. Well, hello, everyone. Greetings to each of you. As was said, my name is Laura Ellen, and I'll be providing a brief overview of implementation science and describing some potential intersections between climate change, implementation science, and specifically environmental justice. So my current sources of funding include the NIH, the VA, and the Penn Medicine Health System. The views expressed here are my own and do not represent those of the Department of Veterans Affairs or the US government. To help give some context to my own lens and frame of reference, I am a social worker who recognizes the harm caused by the field throughout our history, specifically the generational and societal harm perpetrated by white women in child welfare. I'm an implementation science methodologist who works to equitably and justly support the use of evidence-based practices, while also understanding that evidence can be found through the lived experiences of communities. I'm also a first-generation academic. Finally, I come to this work as someone who grew up in Lancaster County, Pennsylvania. Lancaster is often known for its Amish and Mennonite farms. However, what is less known is that Lancaster County has historically had some of the worst air quality in the US, with some improvements over the past decade. I then lived in the Mon Valley just south of Pittsburgh for 9 years, where geographic and industrial factors result in many days of poor air quality. The interaction of air pollution and climate change continues to be amplified in my communities of origin. And while I'm not a climate scholar myself, my lens and experiences give me a passion for integrating implementation science and climate change, specifically environmental justice. So with this in mind, I'd like to introduce implementation science. So we often think about what is our current state or social problem, such as the degree of air pollution in our community, and where would we like to be? A reduction of that air pollution with the ultimate goal to reduce the effects of climate change. However, the difference between these two can feel like such a great chasm. We then try and tell ourselves that this gap is fine, even when everything is burning around us, and in some cases, literally. As I hope you will agree, the gap between what we currently experience and what we want to experience is not fine. As demonstrated by you being here today, we each want to do something about this great chasm. So this is where implementation science comes in. The field of implementation science uses multidisciplinary approaches to address this gap. The NIH defines implementation science as the scientific study of the use of strategies to adopt and integrate evidence-based health interventions into clinical and community settings to improve individual outcomes and benefit population health. That can be a lot to take in, so let's think about it in a little bit of a different way. Jeff Kern introduced the language of the thing as the evidence-based practice and describes implementation science as the ways that we can support and empower communities and people to do the thing and continue doing it over time. Another way to think about implementation science is the examination of behavior change. So with this in mind, what exists at the intersection of climate change, implementation science, and specifically environmental justice? Together with this esteemed group of colleagues, we examined the environmental justice literature, specifically at the neighborhood and policy levels, with the intersection with implementation science. So we recognize that environmental justice must be at the center of efforts to address climate change. For this paper, Drs. Cabrera and South provided expertise in environmental justice, and Dr. Lane Fall and I provided implementation science expertise. In our article, we introduced the environmental justice implementation subway approach, a mouthful I know, which integrates environmental justice frameworks from Van Horn and Carrion with the implementation subway first introduced by Dr. Lane Fall. Before the implementation of the intervention, community lived experience and memory alongside goals for their own health must be centered. This includes what actions are already being taken by community members and how can intervention development promote reinvestment in those communities. We recognize, again, that community members are experts in their own lived experience, and this includes allowing communities to identify their own practice of interest or the thing. The next step is then to identify whether or not the practice of interest or thing has shown efficacy. We also recognize that traditional approaches to knowledge generation are not always feasible or ethical. So if traditional approaches have not been used or can or should not be used, another way of framing this subway stop is to ask the question, could this intervention or thing address larger goals, such as improve population health or address climate change? If the practice of interest has some foundational efficacy work or is believed to be able to address larger target goals, the next step is to consider effectiveness research, or how does the intervention work in real-world settings? Traditional approaches to this include quasi-experimental or observational studies. However, we posit that traditional approaches to effectiveness research may not always be needed to begin implementation. Again, depending on that degree of need, it may be appropriate to use a hybrid effectiveness implementation trial. So, for example, a hybrid type 1 trial focuses on testing the effectiveness of the practice of interest, the thing, while also collecting qualitative data about factors influencing implementation, such as acceptability or feasibility. Implementation trials then test factors influencing how to best support individuals or community members to use the practice of interest or thing, and often include both qualitative and quantitative data collection and analysis. So, for example, let's say our practice of interest, our thing, is park-based green spaces, and our effectiveness research aims to see if real-world greening improves air quality in a community. We can test the implementation strategy of building coalitions to obtain funds to develop the green space, and then the implementation outcome of sustainability or durability of the green spaces over the next 1 to 2 years. Over time, we can then examine which strategy or strategies best support the ongoing maintenance of green spaces. In order to address the larger challenges of climate change, it is critically important to have communities at the forefront, to make time and space to remember and reflect, restore and reclaim, and reinvest throughout every stop of the environmental justice implementation subway approach. Thank you. Please feel free to reach out. I'm always eager to hear and support the work that's happening in the field, and I look forward to our conversation.
Wonderful. Thank you so much, Dr. Ashcraft. And I believe that since we are going until 12:30, we could spend a minute or two if anyone has clarifying questions about the content Dr. Ashcraft just presented. Please feel free to put it in the chat. And happy to entertain those questions. And in the meantime, Dr. Hassan, do you, let's see, would you like to start loading? Okay, good. We do have a question. So from Sophie, my question is related to community investment of time. Is there community fatigue with respect to implementation research? It's an excellent question.
Yeah, that is an excellent question. I would say there is likely community fatigue when it comes to research at large and not just implementation research. And thinking about the last session and some of the conversations that were had there about how research often is occurring frequently over and over in the same communities. I would say some of my experience has been that when we get to implementation research in particular, and especially pragmatic approaches to implementation research, there is often quite a bit of action that tends to happen, and that can be invigorating for community members. That can be inspiring for them to continue moving forward. So I suspect that that is a question to ask and to listen, especially as someone coming from an academic space. If it's not my community, I'm there to listen, to absorb, to hear how I can support, how I can leverage my resources to support what's happening, and hopefully reduce some of that community fatigue that may be occurring.
Great, thank you. And I imagine that question will also be relevant to the other presenters. I think we can take time for one more question, and then I'd like to turn it over to Dr. Hassan. I do appreciate everyone putting their questions in the chat, because then we can get to them at the end as well, but want to make sure every speaker has a chance to speak. Also, I realize that the numbers of participants have doubled since we did an initial introduction, and I neglected to introduce myself. So just to take a moment, I'm Gila Netta. I'm a program director at the National Cancer Institute, and part of the NIH-wide Climate Change and Health Initiative, and delighted to have this session on implementation science at the Nexus of Climate and Health. So with that, we'll take one final question from Dr. Schleier or Titus. I hope I'm not mispronouncing your name, and then we'll move on to Dr. Hassan.
Yeah, thanks, Gila. My question relates to the time horizon of implementation science. So many times I see kind of, short-term, 1 year, 2 year things. You use the example of green space. Well, that has to be maintained for a long time. So how can implementation science help us with the long time horizon of some of these projects?
Yeah, I think an excellent point, and something that as a methodologist who works on many different studies, it is the ever existing struggle between the incentives that academics often have to get to that next grant cycle, the time limits, constraints on grants as well. And so one of the ways that I have tried to encourage the folks I work with and the projects that I work on is to think about sustainability at the very beginning of your implementation process. That does not mean that if your implementation or your intervention does not turn out to have the outcomes that you want, that you're going to continue to do that over the duration, right? That's a whole other thing about de-implementation, which we're not going to get into today. But I think beginning to think about what are the factors needed, what information is needed to really understand how can we empower community members, how can we provide the infrastructure. This is where this reinvestment part comes in. How can we ensure that we, as the often external people, the academics, provide the resources needed that community members can continue to maintain and sustain their own work. And so I think that's where some of the learnings and lessons from implementation science can come in, but it really is a struggle. So I'm eager to hear how the other speakers have thought about this as well.
Great, thank you. And that's a perfect segue to Dr. Hassan. Thank you, Dr. Hassan.
All right, so let me know if you're seeing it in the right mode and everything looks good. Thumbs up, or is it?
Yes, right mode and everything looks great.
All right, great. So good morning, good afternoon, good evening, everyone. I'm Sadia Hassan, assistant professor at Emory, and I'll be talking to you today about reducing mortality due to non-communicable diseases during climate-related events, a participatory system science approach. So this audience is well aware that there are a myriad of ways in which, oh, sorry, this is totally not working. Apologies. It's gonna wait 1 minute. I'm really sorry, everybody. I'll stop my share for a quick sec.
No problem.
About that.
And while you're navigating that,
Yep.
I'm just going to note some things from the chat, but I can be quiet as soon as you're ready. So I did just want to point out to Sophie's question, James Hospitalis responded that in LMICs, there may be quite a thirst for it. Oh, great. And it is not in view mode, it is in notes mode.
Okay.
Now it's in view mode. Presentation mode.
Is it now? Still?
Oh, it was in presentation mode. Sorry. It is now. We can notes.
Okay, how's that?
Perfect.
All right. Okay, so apologies again, and please do look at Dr. Hospitalis's note because I'm sure it's quite poignant and relevant. So this audience is well aware of the myriad of ways in which climate change impacts health. So in the center of this graphic from the CDC are the climate change effects of rising temperatures, more severe weather, rising sea levels, rising carbon dioxide, things everyone here is aware of. And these in turn, through several mechanisms, impact health in multiple ways. Now, my interest has been specifically around the impact on non-communicable diseases, some of which you see depicted here. So why NCDs? Well, it's not only the leading killer globally, and you see the 5 non-communicable diseases that I'll be referring to listed here, But unfortunately, it is a dire depiction of global inequities, where 77% of deaths occur in low and middle income countries, 86% of premature deaths occur in low and middle income countries. And unfortunately, climate change will only worsen this. And so this table from 2010 Friel's paper really looks at the ways in which climate change impacts NCDs, thinking about both direct impacts through things like extreme heat and changes in our air quality, to indirect effects like extreme weather events, which is what I study. But the other reality is that, as Dr. Vanessa Carey mentioned yesterday, there is also an inequity in the way in which climate change impacts health overall. And the populations and the countries that contribute the least in greenhouse gas emissions, you see in the top panel here, unfortunately suffer the highest burden from greenhouse gas emissions, as you see down here. So I call this now the new double burden. The new double burden of NCDs, which I've already showed you, have inequitable effects, and now climate change having inequitable effects. And so this is really a call that without intervention, we will see worsening global health disparities. And as Dr. Ban Ki-moon had put it, climate change affects us all, but it does not affect us all equally. Those who are the least able to cope are being hit the hardest. But how do we operationalize that? How do we start thinking about vulnerability, especially as we kind of think about it from an implementation science lens? So the Environmental Protection Agency developed this framework, which I found very helpful in thinking about linking climate change, health, and implementation science. The idea that vulnerability is a function of your exposure, so self-explanatory, your exposure to climate-related weather events, for example, but also a function of your sensitivity, realizing that there are some individuals who might be more sensitive to those effects than others, and then ultimately adaptive capacity, your ability to adjust to these hazards. So using this framework and thinking of vulnerability in this way, let's look at one specific type of exposure, which are climate-induced severe weather events. And as you all know from the recent IPCC report, yes, in a changing climate, extreme events may be unprecedented, and they're going to occur in larger magnitude, in increased frequency, in new locations, with different timing, and unfortunately, differing combinations of all of these things. The Caribbean, which is where I do a majority of my work, is unfortunately a region that ranks at the very top in terms of casualties from storms. That's your exposure, so high level of exposure. And unfortunately, this devastation has been evident over the past several years. But not only do they have high exposure, they have high sensitivity, especially when we think about non-communicable diseases. So this data from the Economic Commission for Latin America and the Caribbean shows that if you look at disability adjusted life years by type of NCD, for all the NCDs, the orange bar is higher, showing that in the Caribbean, it has the highest premature mortality from NCDs in the Americas. So let's now think about the combination, the kind of intersection between disasters and chronic disease. And much of this data has actually come from unfortunate recent events here in the United States, where we now know that at least 30% of the deaths after Hurricane Maria were due to uncontrolled NCDs. And these are a combination of things: myocardial infarction, heart diseases, dialysis, people with diabetes, cardiovascular disease, other neurologic problems, and importantly to mention, mental health. So the goal in our team is to strengthen the capacity at both the individual and the institutional level to address the needs of people living with NCDs in the setting of climate-related extreme weather events. Again, thinking about vulnerability as that function of exposure, sensitivity, and adaptive capacity. How do we work on that adaptive capacity piece? So the example I'll share is from our work in the US territories, US Virgin Islands and Puerto Rico. There you sit in the Caribbean, which I've already told you has high levels of exposure. And unfortunately, they also have very high levels of sensitivity. From underlying disparities, some of which were outlined in this paper from Dr. Nunez-Smith, looking at quality of care in the United States compared to the US mainland, and showing that there were several additional deaths per 100 in the US territories. So higher exposure, higher sensitivity will lead to disparities unless we act. So the objective of this project was to engage affected communities and interested parties to identify strategies to reduce morbidity and mortality due to NCDs in the setting of these events. Our work is guided by an implementation science framework that's known as EPIS, Exploration, Preparation, Implementation, and Sustainment. We chose this framework specifically because it was developed to guide implementation of evidence-based programs in publicly funded settings. What's also nice about EPIS is that it urges us to make sure we are thinking about those inner and outer setting contextual factors that are so important to consider during the entire implementation process. And so this is how we overlaid our project on top of EPIS. What I'll be talking to you today is the exploration and preparation phases. And now we have grants that are under review to look at implementation and sustainability. To do this work, we used a participatory system science approach. And I will say system science is now being increasingly used within implementation science. So it's an approach that describes and allows us to understand the causality and the interrelationships between variables in a very complex system. And as you can imagine, disaster response, even disaster preparedness, are very complex systems. If you've heard of system dynamics, that's when you take it to the next level of now attempting to quantify the impact of those interactions. Participatory approaches are key. And as Dr. Ashcroft had mentioned, much of what we do has to be driven by the stakeholders and the communities where the work is being conducted. And so making sure that our participatory approach is ingrained in the principles of community-based participatory research is really the only way to lead us to feasible, acceptable interventions that will be welcomed by that community. So there are many methods within system science. We chose to use participatory group model building. This is a means of engaging diverse stakeholders in a process to lead us to understand that complex issue. In our case, the problem is the number of people with poorly controlled chronic disease in the setting of a climate-related event. The process that you see outlined in the figure here basically helps us lead stakeholders and transform their own mental model of a problem into an explicit causal diagram that depicts the important variables, so the causes and the consequences, and then how they're related. By looking at these diagrams, you can then start to find intervention points. So again, the stakeholders, the community members, they are really the essence of this work. And so who is at the table is absolutely critical. And so we engaged our own community advisory board to start thinking about who the interested parties were that needed to be part of our discussion. And you see them listed here. Then we had a series of meetings. The steps are really defined by the process of group model building. We unfortunately had to start virtually because of COVID-19. We started by defining the problem, its causes, its consequences, finding the relationships between them to develop these causal loop diagrams, and then use those interlinkages to then finally identify intervention points. This is just an example of the different causes and consequences. Let me just walk you quickly through an example. Persons with poorly controlled chronic disease, mental health problems is a cause of that. It increases the problem. You have worsened chronic disease, leads to medical complications, decreased productivity, negative financial consequences, more mental health problems, more uncontrolled chronic disease. And the diagram can become more and more complex. And you see us here in a virtual meeting over this diagram trying to make sense of it, with the final product being this, which the point is not to show you the details of this, but really to show you the complexity of this problem. But within this complexity are stories, and these are highlighted here: mental health, homelessness, awareness of your condition, access to food, access to medication. And these stories become your intervention areas where if you intervene, develop strategies to address this, you can then reduce the problem of people living with chronic disease. And that's exactly what we did. We worked with our community members and the stakeholders to prioritize those issues from the stories that they wanted to act on. This is one example of something we already started, which is educational material to raise awareness about NCDs and disasters, which you see right here. But there were many others, and you see them listed. That was both at an individual level and at an institutional level, but there are also system level changes that were needed, especially with regards to access to healthy food. These were the food packages that were delivered to survivors of Hurricane Maria in Puerto Rico. And as it says here, you either get diabetes or hypertension in a box. So clearly system level interventions are needed here. And so we then use this to say, okay, so if these are the strategies, well, what are the evidence-based interventions that are already out there that can help us address these issues? Chronic disease self-management program can help us increase self-management of disease. Community health worker-led mental health and psychosocial support programs can help the issues around mental health. Community and organization registries can help us identify people who are increasingly vulnerable. And examples such as the World Health Organization NCD kits can provide us with those medications and supplies and the flexibility that we need post-disaster to give NCD meds. And pharmacist-led prescription refill programs can help us address access to medications after disasters. So that's what we're doing now, is taking those evidence-based interventions, creating a combined multi-level intervention, implementing it, and then hopefully sustaining it, which is what one of the other questions was about. So in summary, really, climate change is going to worsen global NCD disparities. We must act now. Individuals with NCDs are particularly vulnerable. Think of vulnerability as that function of exposure, sensitivity, and adaptive capacity. There's really a huge need to integrate implementation science so that we can develop those evidence-based strategies that can strengthen adaptive capacity. And we really hope to be able to continue both our participatory approach and using these other tools to now move to implementation and sustainability. So with that, I'll end. Apologies, I went a little over. Thank you all.
That was wonderful. Thank you, Dr. Hassan. And what a wonderful example of applying implementation science early in your even intervention development phase, thinking about which interventions and selecting which interventions need to be implemented. And so using your example is a great example of thinking through what adaptation strategies do we need to apply and getting needed community input on that question. So if anyone has a pressing specific content-oriented question about Dr. Hassan's presentation, feel free to raise your hand or put it in the chat. Otherwise, we will move on to Dr. Pan, who will be talking about early warning systems. And I don't see any raised hands or questions in the chat. So if any questions come to mind, do feel free to write it down, and then you'll have an opportunity at the end.
Should I take it away?
That's great. Thank you. Please do.
I don't know if there's any questions for following up on the previous speakers. I'll give you all a second to think about it. I see some chat, but I don't know if those are questions.
I see that somebody added a question in the Q&A, and my apologies. The format that I'm looking at, I don't see how to access the Q&A. So I think once the presentations are done, we'll make sure to grab those. Oh, and then there is one question. So are there evidence-based implementation strategies that should need to be compared to determine which is best to address climate change and health? And I think that is a great question and sufficiently general that if the questioner doesn't mind, I will hold it until the end, because I think that would be a good question for all of our panelists to address. Great, thank you. Okay, so go ahead, Bill, take it away.
Okay, thanks everybody. Thanks for showing up. We have 102 people. I know this is virtual, but I did want to say hello to some folks online like Kaushik, Abby, and Richard. Good to see you guys. I'm glad you're attending. Richard, we miss you at soccer. So my name is Bill Pan. I'm at Duke University. And the theme that I'm talking about obviously is very similar to what's already been addressed, but I'm specifically focusing on the question about implementation of climate early warning systems. So just to give you a brief kind of overview of what this will do. So I'm just going to talk about the motivation of why you are listening to me and why you might be interested in this topic. aspects about implementation science that we're using to evaluate it. Some of this was already reviewed, so I'll go over that very fast. The challenges that we're seeing, and then some very basic recommendations on how to move forward. So this problem is motivated slightly differently than what some of the prior speakers were discussing. So what we're dealing with are surveillance systems in different countries. So we work in Ecuador, Peru, Brazil, Panama, and Honduras. Right now, we're working primarily on malaria. And this is what a common dashboard looks like for the Ministry of Health, where they will sit down every single week, look at this dashboard, and try to figure out where they want to deploy certain resources to control malaria in this case. So they'll look at this. This is a weekly epidemiological list of cases. They have a nice map that shows the distribution of cases. And so a couple of things that I wanted to point out on this dashboard. So the first thing is, I downloaded it last night just to make sure that it was updated. Today's February 7th. The updated data go to epidemiological week 4, but we're in week 6. The problem here is that week 4 actually isn't too bad, right? So that's only 2 or 3 weeks ago. In reality, we know that the data are not 100% updated. So in other words, people are coming into health posts. Oftentimes, if they're getting diagnosed with malaria in this case, there's no electricity in a lot of these places. It takes a very long time for the paper form to get sent to the database and get uploaded so that the decision makers who are deciding where to give resources to, they're actually deciding on cases that are about 4 weeks, that have occurred 4 weeks ago and have been reported 4 weeks ago. So there's a little bit of this lag. The other big thing that happens here is that these, within these districts where you're looking at malaria occurring, we don't have a good visualization and a sense of how malaria is trending in each one of these districts based on the dashboard. And we don't really have a good sense of what's happening right now, which is what I was just talking about. This is mostly cases that have occurred cumulatively up in the year. Then with this dashboard, for example, there's absolutely no integration of environmental data, climate, land cover, hydrology, nothing. They do have, some countries are using climate data and health data together, but only in the sense that they're showing trends and not putting them together to make any kind of inference. The second thing is forecasting. So if we wanted to figure out what was happening in the time when we know that 100% of cases are reported up until today, and then from today going forward for 4 weeks, 8 weeks, 12 weeks, that kind of information is not currently used or produced in any kind of early warning system, a surveillance system now. And then the last thing is just the fact that this is a decentralized health system. But what's happening is that community health workers are reporting the data up to decision makers, but the information on what they're supposed to be doing is top down. So there's not an integration of the decision with the community health workers to make sure that any kind of intervention that's deployed is context relevant, which I believe the last speaker was really hammering into about this need to engage people at the local level. So what have we done? So I'm going to be talking about early warning systems. There's a couple of them that exist globally. Ours we have operating right now, as I said, in Ecuador, Peru, and Brazil. And this works by creating a real-time climate system merging with land cover. All of that information is merged together with government surveillance, as well as interventions, putting in population at risk. And we create different scales of forecasts, both at something we call an eco-region level, and then we scale it down to districts and communities. And then what we can do is basically create something called a nowcast, which means we fill in the gaps of how much disease exists between the delay in reporting and now. And then we can also forecast forward about 8 to 12 weeks. And we can actually predict outbreaks with about 90% sensitivity and specificity. Now, there are other systems that can do this, and there's other ways of doing this other than the methods that we show. However, the biggest problem that a lot of people have is the fact that climate early warning systems have two big challenges in implementation science. The first one is all the health problems that have been discussed in the last couple of speakers. We have all of those issues in terms of engagement. How do you adapt different interventions at the community level? How do you get people to buy in to different technologies? Our other big challenge is just the fact that decision makers have to believe that climate and land cover data can actually improve their decision making. And that, shockingly, is a very hard thing to convince people to do. All right. So we looked at a couple of early warning systems, and we used different ways of evaluating this using implementation science frameworks. And some of this was already presented, but I did just want to say, and I don't want to present an implementation science framework because I'm the last person you want to probably hear that from, but there are two big frameworks that we draw upon or that we have looked at. One is the Consolidated Framework for Implementation Research, which has 5 domains. It's a very comprehensive framework to understand how factors influence implementation effectiveness. These 5 domains are the intervention characteristics, the characteristics of individuals that are actually adopting, the inner and outer settings, and then the process of how you go through and evaluate and engage people. The second type of framework that's very useful is Proctor's Outcomes for Implementation Research. And it's called Proctor's Outcomes because it was written up by Enola Proctor. And there's 3 domains here, which are really implementation outcomes, the service outcomes, and then the client outcomes. And these, there's a lot of overlap between these two. And all I would say is that the Proctor's Outcomes are actually very good at defining and measuring the outcomes for implementation research, whereas the CFR framework is really to understand, in my opinion, some of the ways that implementation is going on. But that can be discussed later. So I wanted to point out something about, I had mentioned earlier, the challenge of climate and health projects. So very quickly, I looked up on PubMed how many publications there were that used the word implementation science, and this is a field that's taking off. But if you looked at implementation science with climate change adaptation, or climate and health, you all of a sudden come up with a much smaller number of articles that can help guide how to use implementation science in a climate change adaptation framework problem. And Enola Proctor actually did a recent scoping review that was published last year, where they reviewed 1,300 manuscripts that were published between 2012 and 2020. 400 of them were selected. So they find that 67% of these studies were mostly done in healthcare or behavioral health organizations that focus on inpatient and outpatient settings. 15% of the studies were in schools and universities. There were 14 innovations or interventions that were classified. There were 14 health conditions evaluated. None of these had anything to do with a climate health connection or using climate or environment as a risk factor. So this area is ripe for improvements in the application of implementation science for climate and health. All right, so Gila had mentioned early on when she introduced me that we had worked on evaluating case studies using the CFR framework just to evaluate the challenges of implementing early warning systems. So what we did is we looked at, the case study that we have in the Amazon, one that Mike Wimberly runs in Ethiopia, another one in India, Barbados, and then the Marshall Islands in Micronesia. These were some were malaria, some were dengue, but they all were based on the idea that where they're using climate and environmental data with some kind of local surveillance data to make forecasts about the vector-borne disease. And we use the CFR framework to really apply and evaluate the barriers. So the summary of what we find, I'm just going to go over the most common challenges because you can look up the paper and read it in more detail, but I want to highlight a couple of things. The most important problems that we found that all the sites complained about was, number one, there was no funding for sustainability. So what does that mean? That means that local partners the local governments and institutions that were adopting the technologies that we're creating often lacked funding to engage, meaning they didn't have funding to provide a technical person to help develop, test, and jointly implement these programs. The second thing is with data management. So as I said before, we're dealing with climate and health data. Finding people that actually have the skills to manage very complex databases are in short supply, not just in high-income countries, but we're dealing with low and middle-income countries, so that's even harder to find. Similar to that, capacity training for data science and GIS. We're finding that this is a niche in epidemiology, having the spatial data management skills and spatial analysis skills, where if we want to hand off something on how to run a forecast model that's very spatially explicit, that actually requires a lot of capacity training, not surprisingly. The other thing that 4 sites noted was a lack of decision support protocols. So what that means is that usually when people declare an epidemic or an outbreak for a certain region, it's based on data that you're seeing that are recent or current. If we have a forecast that says in 4 weeks, 8 weeks, 12 weeks, we're going to see an outbreak with a certain probability, there is not a policy tool currently that allows them to redeploy resources effectively. So there's an internal policy problem that we need to overcome. And the last 2, which have been mentioned in prior talks or the last speakers, are local ownership. This is always a problem. How do you get the agency and institution to have the time and political commitments to actually want to adopt, especially in a government agency when you have turnover every time you have a new government that comes in? And sometimes actually you have ministries of health and ministries of environment that need to share data, and that sharing doesn't always go so well, especially in siloed government ministries. And the last one that really occurs across many sites are overburdened government workers. So the roles and responsibilities of government workers in low and middle income countries may be the exact same as high income countries. But the problem is, because governments often work inefficiently in low and middle income countries, they have a lot more time that they put towards trying to do the same types of jobs as someone in the equivalent job in a high income country. So that ends up being a big burden. All right, so just to sum up, where do we go from here? So as I said, many of these things are written up in the paper, so you can see them and read through them in a lot more detail. All I would say is, number 1, climate and health researchers need to think about implementation from inception, and you need to define those implementation outcomes in collaboration with the adopting institutions as soon as possible, because those are things that really help buy-in. And the last thing is really for a funding agency. Funding agencies cannot just support just the research or just the implementation when we're dealing with climate and health problems. They have to support both at the same time. Otherwise, you'll end up what we have is a lot of challenges in trying to implement these things. So happy to take some questions and discuss this. But thanks a lot, everybody, for listening.
Wonderful. Thank you, Dr. Pan. That was a great overview and a great example of applying implementation frameworks, and also touches on one of the questioners' questions about why are there so many frameworks. Different frameworks serve different purposes. So the consolidated framework for implementation research is a useful framework to understand what are barriers or determinants that influence implementation. And Enola Proctor and others framework, Proctor's outcomes framework, is a useful framework for conceptualizing what are the implementation outcomes we're trying to achieve? What are the implementation challenges we're trying to solve? Is it adoption? Is it penetration? Is it sustainability? And making sure that we're conceptualizing those things and measuring them so that we know our implementation efforts are working. I think we can field more questions later, but if anyone has a specific question for specifically Dr. Pan's talk, feel free to put it in the chat. And many thanks to the conference organizers who are translating the questions in the Q&A to the chat. Unfortunately, I can't see the Q&A, but we will make sure to get to those questions afterwards. So I don't see any raised hands or any additional questions unless I'm missing something. So I think if it's okay with you, Bill, we will move to Aruni, and then we'll have a broad conversation with the full panel. So thanks again so much for a great talk. And Aruni, are you ready? Wonderful. Thank you. And everything looks great, but can you go off mute? And I want to make sure you also sound great.
Okay.
Perfect.
Okay, there. Can you see what I'm saying, the screen?
Yep, it looks great. Thank you.
Okay, so good afternoon. I'm Aruni Bhatnagar. I'm going to talk to you a little bit about our work on not so much as implementation science as much as implementation per se. So what we are doing here is to look at how we can implement certain strategies to change or to mitigate the effects of climate change and certainly environmental degradation. And so these are some projects that we've been working on. So I want to discuss that with you. We all know that there is a lot of information about how there is a change in the climate, how we are changing the planet in some cases irreversibly, and that there are some changes that are going to be problematic in terms of the climate change, in terms of its health implications. We have known for a long time that there's been a consistent increase in the temperature of the planet, and then this has caused a variety of different environmental changes, as well as changes in public health and in individual health. So how do we address these issues? And though there are a variety of different strategies and we can do a lot of work in different directions, one way of addressing is to be able to change the actual green spaces that surround us. And I think there is a certain set of reasons which are important in terms of understanding and in terms of evaluating the effects on either the environment or on human beings. And vegetation and green spaces are particularly potent in being able to affect both such changes. It affects positively our environmental changes, and it has positive effects on the environment in terms of actually creating a healthier, sustainable environment, but also remediating environment, preventing environmental degradation, and making the environment more conducive for healthy living. At the same time, there are effects on human beings, which actually have a variety of different effects, could be health effects, could be with physical health or mental health. So knowing that there could be that green spaces, and particularly greenery, vegetation, could be one way of mitigating the effects of climate change, how can we implement these sort of changes and make positive changes within a community? So in order for us to sort of get ourselves oriented and to be able to understand whether these change with greening interventions would be helpful, we did a study in which we actually recruited a range of individuals from the city of Louisville in Kentucky, from different areas around the city. And then we looked at their levels of exposure by measuring the urinary metabolites of volatile organic compounds. And these are things like benzene, xylene, toluene, and so on. And we look at the differences in the urinary metabolites and people who live in different levels of different greenness. And we found that those who live in higher levels of greenness had much lower levels of exposure. So it means that green spaces can decrease the levels of stress. We also then looked at the levels of stress by measuring things like changes in the greenness or the greenness around a person's house, as well as changes in the urinary epinephrine levels, which are a marker of stress. And we found that the more greenery there was around people's homes, the less there was of epinephrine in the urine. So suggesting that if you live in greener areas, you have much lower stress. So both environmental and human health effects could be realized in people who live in areas that are greener as compared with people who live in less green areas. So we also see that some of the effects of air pollution, for example, in this case, we measured the effects of PM 2.5, and we see that if you live in areas of greenness, then you have lower levels of changes in your arterial stiffness upon exposure to air pollution. And which means that in some ways, greenness can shield against the effects of air pollution. So we started this project, which we call the Green Heart Project. And what this project was a partnership between a variety of different stakeholders, including the University of Louisville and other universities, NC State, Cornell, WashU, but also community organizations and the Nature Conservancy and the city of Louisville. So what the hypothesis of the study was that exposure to neighborhood greenery could decrease the risk of cardiovascular disease by decreasing the levels of air pollution. And so this is an interventional study, say, if we go to a neighborhood, and if we increase the levels of greenness in the neighborhood, would that change the health status of that community? So this is sort of a rather daunting project. That's why I have a wide range of people with an array of different expertise. So for the study, what we did was we looked at, or we adopted, so to speak, 8 neighborhood clusters, which we call the target clusters, and then 8 control clusters of neighborhood in South Louisville. These are middle-income neighborhood with the average income of about $35,000 to $40,000 a year. It's a mixed neighborhood with about 19 to 20% Black population. And we worked there for a couple of years trying to understand the neighborhood, the people living there, and what the actual needs of the community was. And certainly greening was one of the top 3 priorities of the neighborhood. So then we spent a lot of time, maybe a couple of years, in looking at the levels of air pollution in the area, which is this is shown here, which is a mobile monitoring. It's about a graduate student driving around in a golf cart, looking at levels of air pollution at all times of day and night in different seasons. And this is where we found that higher levels of air pollution around roadsides. We found high levels of air pollution around fast food places and so on. So we could develop a high resolution map of the neighborhood to be able to then do evidence-based planting. So we can then plant the trees and shrubs in areas that have high levels of air pollution. As you can see, there's a freeway that runs through it. Within the neighborhood, there's a sort of a legacy of redlining. And then we can see high levels of pollution around that area. So next we did is we recruited participants from the community, between 500 and 700 people, and we conducted in-person exams, and these exams are very complicated and long exams, which take about an hour and a half. And we look at a variety of different parameters, including blood pressure, lipids, and so on. And then we wanted to plant trees. And so if we were to plant small trees, it would take us, 20, 30 years to get appreciable change in greenness. And so we planted some very large trees, some of them over 20, 30 feet tall. And then also there were some shrubs in between. And so we had to bring trees from all over the country to be able to afford to get very large trees and increase greenness sort of quite rapidly in the place. There were places around the freeway that we wanted to plant, which would actually shield the neighborhood from the impact of the roadway traffic, because our roadway conditions are very bad. We'd have to do some significant soil remediation in many, many places within the neighborhood. And we planted trees and we got trees from all over the country. Actually, we got them in semis, and we got them to be at a particular staging station. They were transported to different areas where they're supposed to be planted. And we planted trees not only in the free, but also the neighborhood. We went door to door asking people if we can plant trees in the front yard and backyards. And so we had to bring these trees in and arrange them in such a way that, at least in the freeway, there were large trees at the back and small in the front. So provide a gradient for the dissipation of air pollutants. This was some of the initial pictures, before pictures. We got some trees that started planting, and this is what it looked afterwards. And this is just one section of the neighborhood that we planted. We, like I said, we almost completed over 8,000 trees. And so this is sort of a final picture that we have. We had in this neighborhood in these 8 neighborhoods, about 6,000 trees. After we were done planting, we had more than 8,000 trees, mostly evergreen trees. We did plant over 42 different species of evergreen trees from 5 different families so as to preserve biodiversity, and so not to overwhelm the area with just one type of species. And we did not plant anything in the control clusters, so we can then compare health outcomes between the target clusters and the control clusters to be able to look at that in terms of the framework of a classical clinical trial. This is like a community-based clinical trial with the trees as the intervention. We just finished planting last year, and so we are still in the process of getting the data and trying to understand what it is, how much greenness has been changed and how it's affected the health of people, including how it's affected the levels of air pollution. So what we hope to learn from this is to be able to understand how to plant trees in an urban location, how this increase in greenness would affect health. And if we increase green spaces, would that affect mental stress and social cohesion and other sociological conditions? We're measuring social cohesion, we're measuring anxiety, depression, well-being, and so on, so that we're able to distinguish whether the effects of greenness are entirely driven by psychological or mental effects, or whether they're actual physical effects. And then we look at some of the sociological implications. How does greenness affect crime rates, property values, stormwater runoff, energy use, heat island effect? There are concerns about gentrification. There are concerns about maintenance and sustainability. We have set up funds so that any tree falls, any tree, not even the ones that we planted, any tree in the neighborhood falls, that we would pay for removal of the tree, because that's really expensive for our neighbors to be able to remove those trees. And that's one of the major fears. People don't want to have trees in the backyards and front yards. So that we would be able to then support this in the long term. Finally, we did another small project. This is a microforest project. We know that one of the problems with climate change is the urban heat island effect, and that causes us heating in urban areas. And we have one of the worst heat island effects in the country. So we took a square in downtown Louisville, and this square here has some very sparse planting. And what we are doing currently is to be able to evaluate the microclimate of the area. And this microclimate means humidity, temperature, air pollution, as well as how it affects people. We have people walk in this area, and we have them connected to measuring devices, so we can measure heart rate variability, as well as we can do blood draws to measure cortisol levels and so on. So we want to know how people interact with the space and what is the microclimate in the space. And then this spring, maybe in March or April, we're going to plant trees in the area and create a microforest. And this is our plan, to create a central microforest and then have a surrounding area, so that we can create this small forest to be able to understand how that would change the heat island into that area, the levels of pollution, and also the way people interact with that space after it's been green. So what we hope to learn from that is to be able to find some ways to prevent heart disease. We know that heart disease in communities is driven in part by exposure to air pollutants, particularly in underprivileged community and underserved communities. And so we would want to understand if greening could be one intervention to decrease the rates of heart disease, decrease the rates of air pollution, manage temperature changes, and develop new urban policies and guidelines and building codes, so that we can create more healthier living environments, and then to be able to understand this in terms of a widely formalized implementation framework, so that we can create this as a model that could be implemented in urban localities around the world. So thank you very much.
Thank you so much, Dr. Bhatnagar. That was wonderful. And there are a few questions in the chat for you. So questions basically around the cost and how was this supported?
Yeah, so this is an extremely costly project. The total project is over $15 to $16 million. And about $8 million of that was supported by the Nature Conservancy. They did a global cities fundraising campaign for us from around the world to be able to afford to buy these trees. Each tree, as you can imagine, cost over $1,000 to buy and to plant. And if you get, going to plant, 8,000 trees, you can imagine how much that would cost. But we wanted to really do a significant experiment, not to do it piecemeal. We got about $4 million support from the NIH as far as doing the clinical work and doing environmental monitoring. Then we have some local sort of philanthropic support that we were able to garner from people around who lived around that area, and the community supporters. So that's how we were to put it together.
Great, thank you. And then there's a question, are there plans to look at renal disease, also sensitive to heat?
Well, since we don't know much about it, because we are from a background in cardiology and not so much nephrology, so we don't have much expertise as such. But yes, we are looking at renal function. We collected urine samples from everyone, and so we would look at a detailed analysis at renal disease as well as liver disease, and we want to see whether those outcomes are different. The other thing that we are doing as such, though, is this is a community of 35,000 people who live there. And although we do an in-person exam with only 500 or 700 people, we can follow outcomes, hospital admissions for the entire population in these clusters, so that we will know if there's something that did not anticipate, like renal disease or in some sort of cancer, then we will be able to follow those as well. In fact, there are studies that people who live in green areas have lower rates of suicides and and different birth outcomes. So there could be a variety of different outcomes that we can look at.
Thank you. And then there was a question from Dr. Adams. Lack of green space also contributes to heat exposures, and heat exposures are also linked to CV exacerbations. Was this effect included in your analysis?
Yes, absolutely. We were very sensitive about measuring. So it's such a large project that takes a long time to describe it. So, but we are measuring light, noise, and heat pollution or temperature. We have 60 monitors of temperature around the area, so that we will have a very good thermal map. We have almost about 60 to 70 noise monitors. So we can map temperature as well, noise as well as heat. And then we will be able to relate these maps to what happens after greenery, what happens to levels of pollution, and what happens to health. We're also looking at other things like biodiversity. We have a team of students from our Eastern Kentucky University. They spent the entire summer mapping all the micro and macro biodiversity in the area to see how that will change with greenness.
Great. And there was also a request for references on the positive effects of greening, which maybe when you have a chance you could put in the chat. That's from James Hospitalis, who's involved in a greening project with emphasis on trees for food to improve environment and food security. Very cool. And then there was, okay, this is a response. And I think those are all the direct questions for you. So just want to thank all of the panelists and invite all four of the panelists to turn on your cameras for a broad Q&A, and thank you to the audience for your patience. Oh, and please don't pin me. Okay, great. Thank you. That's wonderful. Thank you, Natalia and Lily and all the organizers for making this easy for us. So yes, I did see some questions specifically about more training and examples of implementation science in climate and health. I do just want to mention, I did put a link to an open access implementation science course that NCI and NIH have hosted in the past. And while it is framed as being a training institute for cancer, it is really broad. The material is foundational and includes Greg Ahrens, who is the developer of the EPIS framework, which some of our speakers have used, and other examples. So please feel free to download that. And great, I see we have a question from Josh Rosenthal at Fogarty. Please, Josh, go ahead. And you are on mute, just so you know, if you're trying to speak. And Josh, I don't know if your hand is raised in error or if you're struggling with the app like I did on the first day of the conference. But while we are waiting for you to be able to ask your question, I do have one very general question for all of the speakers or any speaker who wishes to answer this, which is essentially, what are sort of the biggest motivations in applying implementation science to your work to address climate and health problems, as well as the biggest challenges? And feel free to pick which angle you elevate first. So whoever wants to start, please go off mute. Go ahead,
Yeah.
Dr. Hassan.
Yeah, so I can start. And I think for me, actually, the motivation and what excites me is also the challenge. So I found that, and actually the reason I went into implementation science is recognizing the amount of stakeholder, community involvement and engagement that is required really by implementation science. And I see a comment here also about this terminology that we use. Is it community? Is it stakeholder? And there's been a lot of discussion around what's the, correct terminology, but I like to think of it as the interested parties. So those people with the lived experience, or those people that can influence that lived experience. And so that's really what I have found so exciting about implementation science, and the reason I think it has so much potential to help us find the right solutions and strategies to address the challenges that climate is posing on health. At the same time, it's not easy. Good stakeholder community engagement needs trust, it needs time, and it needs being able to manage power dynamics. And I found that challenging, and I've learned over time. So I do think that for me, that's kind of the double-edged sword. I'll stop there.
That's great. And I see it actually, I think, relates to a question that's in the chat. What, in your opinion, is the best incentive for the community to better engage in implementation research? And I'd be very curious to hear what you all think about that. I would imagine, and I'm guessing, that where the community feels they are being underserved, they would be motivated to have researchers help them address that problem. But what that actually looks like in practice from all of your perspectives as researchers, I'd love to hear. And Josh, I do see your hand is up again. If you are able to go off mute, I will see you go off mute and be able to call on you. Great, go ahead. So go ahead, and hopefully our speakers can hold that other question in their head as well.
Yeah, sorry, I'm struggling with the app. But no, my questions are for Dr. Bhatnagar. And a marvelous study, really impressive. And I just had a couple that are probably a little bit less IS focused than on the specifics related to the study. And that is, you have an experimental design. That's what ecologists refer to as pseudo replication, where all your trial subjects are in one zone and the controls are on the outer. Do you plan to deal with that somehow in the analysis, or just live with it? And both are done, but it does affect the generalizability of those findings.
Yeah, good point. And this is a limitation. And we have, again, going back to implementation science, we have problems with that design because we put greenness in the central zone and none in the surrounding. And the people living in the surrounding zone, we examined them as well. And they were saying, hey, where our trees are, right? You're shortchanging us. So we said, well, so this is what is called a sort of intent to treat framework, like they do in cancer clinical trials. So we said, what we're going to do is we have resources to plant trees in the 8 clusters in the central neighborhood. And the next phase will be to plant around that, so that the control neighborhoods would be planted, and then we expand the rim of the project as such. But there are, the conditions are not identical between control and with target clusters. That's the reason we didn't do one neighborhood, a cluster of neighborhoods, but we did plan to have a sort of structure in which, for example, the freeway runs through both the control and the cluster and the target neighborhoods, so we can match up conditions as much as we can. but it's certainly not the perfect ideal design, but that's what real life is.
Yeah, no, and there's obvious reasons for that. And I just wanted to make one, while I have the mic and the monitor for a second, to respond a little bit to that question you had started with about motivation of the community to engage in implementation science. And what I don't hear talked a lot about very much is the actual desirability of the intervention to begin with. So we usually think about factors that maybe that's about readiness for change, but for instance, an intervention that directly not only addresses their priorities, but also is desirable. So planting trees is a good one, right? Most people will find that appealing. But there are lots of others that might cause them sort of a hassle and make them less desirable of the intervention, desirous of the intervention and participating research. But I'll stop there. Thanks.
Well, I can just begin with our experience. When we started doing this, we went to the community and looked at what are the plans for the community with the development, and greening was one of them. But it's not true that everybody likes trees. We went house to house, and some people just didn't want anything to do with us. Said, get out of my way. We worried about, drugs. We worried about homelessness. We worried about, other things. That what trees are sort of fancy things that you guys have. So, but we did, but some, for some of our neighbors, it resonated, and we actually created this. They couldn't believe that anybody would go to their home and do something good. We said we will plant the trees, we'll water it, take care of it, and so they thought that what's the catch? What are we going to be in for? And so they couldn't believe it. But once they were on board, we built this trust with them, and we have posted this little yard signs all over the neighborhood. I'm a Green Heart member. And so we sort of create a sense of pride in the community about how they really do care about their neighborhood and the way they live. And so now they're really involved. And if we fail to come like on a yearly basis to take the blood pressure, whatever, they say, hey, where are you guys? And they call us. So now that we've developed this relationship, it begins with building trust. And I think that's been the most important lesson for us.
Thank you.
Great. There is a question in the chat. Are there evidence-based implementation strategies that should or need to be compared to determine which is best to address climate change and health?
I can jump in on this one, at least from a larger perspective. I think one of the things and one of the large challenges that exists in implementation science is a lack of evidence surrounding specific implementation strategies in a given context. And this is something that we think about a lot. I think one of the things that can be useful when working with communities, when coming alongside communities to implement an evidence-based intervention, right? The thing as I mentioned, there are a couple of different approaches. There's a process called implementation mapping, which I can put some resources for that in the chat, that really starts from, you can use something like CFR or a framework that helps you to organize factors that may influence your ability to do the intervention itself. And then you use that process to identify, okay, what strategies best align with the challenges that we're facing, the strengths of our communities. I think that's something also when we as scholars and as community members ourselves, right, become embedded and think about what are the strengths that exist within the communities within which we work, within which we live. And then saying, how can we leverage those to identify what is that behavior change that needs to happen in order for us to get to where we want to go? So implementation mapping, is one way to do that. Another way to do that I'm not sure there's a published paper on it yet, but the VA did a really nice webinar on it at some point last calendar year, is a process of creating a shared implementation strategy glossary with shared definitions. And that process, again, these things take a long time, but it can be really valuable to then create trust that folks have mentioned, to create buy-in, to develop infrastructure and knowledge to partner alongside communities to identify the strategy. So that's not exactly telling you. I wish I could say, oh, use these 5 strategies and they're the ones that will definitely help you in this space. And that's just not the case. And it's a process of identifying what are the things that are getting in your way, what are the strengths, and what's happening within that context to really, oh, thank you. Yes, highly recommend that webinar. It was so insightful for me, and I've gone back to it several times. So I think those are my large thoughts on implementation strategies.
Great, thank you. Yeah, and I think the sort of the point maybe of this session is to highlight examples of applying some of these methods. I think in a large way, the climate and health research space is at this point more focused on understanding the implementation challenges. And I think it is critical to understand those challenges before you try to tackle them. And I think the degree to which we can be understanding implementation processes and challenges as we are in real time implementing adaptation efforts, which we all know is happening, the better. And I think the idea is, and there are a variety of methods developed by the field and from other fields that have been applied in the field to rapidly and iteratively examine how our interventions are working and how they can be, how their implementation efforts can be improved upon in real time. And so that is another thing that that this field can help offer guidance on some of those methods. Returning to the question I had asked, I guess Dr. Hassan, you already answered it, thank you, but wanted to give other speakers an opportunity to reflect on any sort of challenges or joys of, applying implementation science methods. Any words of inspiration to this audience who may be struggling with thinking about, should they even go there? Yeah, Bill, go ahead.
Yeah, I think the work that I'm involved in with implementation science is different from the other speakers in the sense that mine is not patient oriented. So I'm not oriented toward an individual or a particular community. So our clients, in the implementation framework are actually the governments that are adopting our system. So that's one level of, I would say complexity on trying to figure out how we engage them in different ways. But then there's also an issue between trust in the government and how the community reacts to things that the government is saying about disease risk related to climate. And what I'm finding, at least in my work, is that if you're in this space, you actually have to work with both groups and you have to consider implementation in 2 different ways. One is if you were to produce visualizations or communication messages, you don't only want to make sure that the government technical workers are understanding the methods and those messages. You have to engage the community at the same time to make sure those messages can also be interpreted correctly, because what we're finding, especially in decentralized systems, that when you lack resources to be able to have the government reach out to communities, they can often respond by themselves without any kind of additional resource. They just need the knowledge on what the risks are. So if you can, I think the area is really exciting and really difficult to work in, but I do think that at least for malaria and other vector-borne diseases, there's just 2 levels of engagement that you need for implementation science. And I think that more people should be involved just because it's a difficult thing to figure out. And it's fun.
So I would agree with that. It's great fun. There are the major joy of doing implementation sciences. If you go to the real world and do things in the world, that things come up that you never expect. So in one particular area, we really really greened up the area, put really large trees. then homeless people started congregating under the streets, right? And so the neighbors started complaining that you create this nexus for all the homeless and people, and there were lots of these needles and people shooting drugs under the trees and the bushes. So we didn't know what to do. So we tried to get people from there, try to get them to move out. But then one night was very cold, and so they just burned all the trees to keep themselves warm. So at least 8 of our trees they just burned to to get the light and keep warm. So that's like a major loss for us. So things like that we never expect that what would happen, and so you learn about what a community is, how people respond to these changes. And you would think that you put in green trees and that everybody will like it. No, but even if we, and at least 6 to 7% of our trees died because they're very large trees, and there's going to be some mortality. And there are a whole range of people who come and tell us, you don't know what you're doing, you're planting these large trees, and this is total nonsense. So you have to be able to maneuver all the oppositions and challenges, as well as the accolades and the appreciation. So that's the major, I found personally, the major sort of effort in trying to navigate this sort of a community scene.
Great, thank you. There are many questions, and I'm just going to put, there's a double question asked by Irene Torres, who I saw actually earlier went on camera. I don't know if she is still with us. And I realize as we're nearing the end, we have 4 minutes left. And I realize people may need bathroom breaks before the next session. So I guess what I don't know is whether the chat will, yes, wise words. Thank you, Josh, to Aruni. And so I think I'll just pause here and stop trying to answer every single question in the chat. And I did just provide my email address. So if people have questions that were not answered or new questions that you didn't have a chance to ask, please feel free to reach out. We will do our best to get you answers. And I just want to thank my panelists once again for their time and their work, and setting a wonderful example of doing such challenging work to address this very critical problem. And any final words from any of you before we close? Motivational words, people asking, how do we inspire the next generation?
I'll just say thanks for organizing the session, Gil.
Ditto. So my only thing is that keep at it. That's the only way to get through anywhere.
Great, well, thank you all, and hopefully more to come. So wonderful. Take care, everybody, and enjoy the rest of the meeting today.